Next speaker is Dr. DWIDEEP Chandran. He'll be talking about anesthesia challenges in pediatric patients.
Dr. DWIDEEP is our pediatric anaesthetist also in our hospital, Contrast Eye Hospital. Over to Dr. DWIDEEP Chandran for his...
Good afternoon. Myself is Dr. DWIDEEP Chandran. So we look into the pediatric anesthesia management thing. Yeah. So initially we'll see what are the anatomical and physiological difference between a pediatric patient and an adult patient. So as we have already discussed, just like in the cataract, the babies are not miniature forms of adults. So there are a lot of anatomical and physiological difference between the pediatric and adult population. The most important difference being their cardiac output is heart rate dependent. Therefore, the decrease in preload and increase in systemic vascular resistance and decrease in heart rates are poorly tolerated. And the goal of treating low cardiac output is to increase the oxygen delivery to the tissues. Our volatile anesthetic agents, the minimum alveolar concentration of these agents in giving effective anesthesia varies with age, but all decreases the BP. Now coming to the respiratory system, the diaphragm and intercostal muscles do not achieve type 1 adult muscle fibers until the age of 2. That means up to 2 years, the kids have an immature muscular system, and most of them are obligate nasal breathers. And then, as we all know, the narrowest portion is a cricoid cartilage. Also, the post-GA apnea is very common because the postnatal adaptation will not occur until 44 years of post-conceptional age. So, this post-GA apnea is common in premature and or anemic patients. Alveolar formation continue to occur until 18 months of age. Coming to the renal and hepatic changes, the complete maturation occurs by around 2 years of age. And the general physiology, they have the minimal ability to shiver for the first 3 months. So we need to heat the whole body, including the head. We need to cover the baby completely before giving anesthesia and doing the surgery. Now, as we all know, why this pre-op evaluation is mandatory in these kids. We know that all these diagnostic issues can occur with the children, like many of the underlying diagnoses and syndromic babies present with the cataract, strabismus and glaucoma. They have this particular set of anesthetic challenges like difficult airway, difficult mass ventilation. Many of them have cardiac lesions, and they do have cervical instability. Like the Marfan syndrome and all are having a lot of cardiac lesions. They can present with the seizures in the postoperative period, and neonates as such have issues with the glucose control, temperature management, postoperative apnea, and bronchopulmonary dysplasias. Now, what are the ASA recommended? American Society of Anesthesiology recommended minimum mandatory workups. So these workups we do for our kids. And most of these kids are post-sepsis survival kids. So it's prudent to see the CRP level along with the CBC when you see these patients, especially when they have some signs of infection like a fever or tachypnea or tachycardia. And we do echo when we suspect a syndromic association which can present us with a cardiac lesion. Now I wanted to clarify some of the myths about the increase in intraocular pressure and anesthesia. So most of the time, the young ophthalmologists think that the anesthesiologist is making your surgery difficult with their drugs and their methods to increase intraocular pressure. So we'll see what are the things about the increase in IOP. So most of our induction agents lower IOP except ketamine. But with the ketamine, the increase in IOP occurs at 5 mg per kg level. So usual doses of sedation like 2 mg per kg or 1 mg per kg of ketamine will not increase IOP, so that your surgical difficulty occurs. And another important thing that we use to avoid the succinylcholine or the scoline the paralyzing agent in most of our kids, because these increases IOP up to 8 mm of mercury, and which will last for about 10 minutes. And ilemodam operates for 10 minutes only. So all this her operating period, this IOP will be higher. So we avoid these drugs. And our volatile agents all over IOPs, and nitrous oxide have minimal effects. Opioids, atropine, and ondansetron also have minimal effect. And on the contrary, are your medication making the anesthesia difficult? Yes, it is, because you prescribe beta blockers, prostaglandin analogs, and carbohydrate inhibitors. All these can cause various problems for us to deal with, like the beta blockers causing bradycardia, arrhythmia, and bronchospasm in asthmatic individuals, and prostaglandin analogs again can cause bronchospasm in susceptible asthmatic kids. And these carbonic anhydrase inhibitors like acetazolamide, topical or oral, can cause mild hyperchloremic metabolic acidosis. And most of these drugs causes renal electrolyte losses. So many of them present with hyponatremia and hypokalemia. And another thing is that our phenylephrine, the most common eye drops we put intraoperatively and perioperatively, can cause tachycardia and hypertension. We had many incidents of accelerated hypertension in susceptible individuals with the use of your T+. So that contains phenylephrine, and the literature says that when these T+ eye drops trickle down the nasal mucosa, that causes the major absorption. So it's prudent to occlude this nasolacrimal duct when you put T+ intraoperatively. And coming to the local anesthetic agents, all these local anesthetic agents, when used topically, also can cause local anesthetic systemic toxicity, what we call as LAST. And that is more true when we are using it for the premature neonates. Coming to individual surgeries, I will brush through these all individual surgeries and individual anesthesia problems, like the EUA, the examination under anesthesia and the measurement of intraocular pressure. Most of the kids used to come to us with these kind of procedures. So we prefer inhalational induction rather than giving IV drugs. And we use a face mask to keep the baby under the anesthesia. And we tell the ophthalmologist to measure the IOP before the airway manipulation or before giving any other induction agent. So we induce the baby with the face mask. Then what we do is we tell the ophthalmologist to measure the IOP. Then we will keep the baby deep for the further procedures. And we keep our anesthesia technique consistent because these kids used to come again and again for measuring the IOP. So we keep our anesthesia technique consistent for the baby. We record our anesthesia technique and we keep it consistent for the baby. Now, glaucoma, most of the cases in larger children, we do it under MAC or IV sedation or GA with a spontaneous respiration. We avoid ketamine and scoline in these cases, and we institute a synchronous intermittent mandatory ventilation, pressure control ventilation modes, and CPAP, continuous positive airway pressure modes for better. Those are better than our unmonitored bag ventilation. Coming to the cataract surgery, the anesthesia should, most of the things I've already discussed, and anesthesia should provide motionless eye and aim for a smooth emergence. The era of crying and struggling babies post-emergence is long gone. So we keep our babies well sedated in the post-operative period, and we keep them under ICU or care for at least 1 or 2 hours. And the strabismus surgery has the highest incidence of exhibiting the OCR. What is OCR? The oculocardiac reflex and postoperative nausea vomiting. Strabismus surgery is mostly painful, and we judiciously use perioperative analgesia, including opioids. And we can give paracetamol NSAIDs for the postoperative analgesia. And ocular myopathies have been rarely associated with a malignant hypothermia. So we purposefully avoid succinylcholine and institute temperature monitoring in our kids. Coming to the oculocardiac reflux is profound bradycardia, which is very rarely can result in a sinus arrest. This is caused by the pressure on the globes and or the traction of extraocular muscles. That's more common in children because they have a higher vagal tone. Is mostly seen as a complication of strabismus surgery, enucleation, vitreoretinal surgery, and orbital surgery. Basically, extraocular muscle stimulation can cause OCRs, and the surgeon should be asked to release the traction on the eye muscles and pressure of the globe as a first instance, and if it is not responding to that, we give atropine or glycopyrrolate. Coming to the post-operative nausea and vomiting, we should understand that ophthalmic surgery itself is emetogenic, and we institute dual therapy in our kids with ondansetron and dexamethasone prophylaxis. And we use as a third agent for the rescue therapy, mostly domperidone or metoclopramide for the kids. And coming to, I will take a couple of more minutes. Blocked nasolacrimal, these kids coming for the short procedures, and in these cases we can use breathing spontaneous with a supraglottic airway devices, and suction catheter can be placed in the nose and pharynx to prevent aspiration. This surgery can be painful and opioid may be needed. Bleeding from the nasomucus can be ameliorated with the topical vasoconstrictors like a T+, and as well as the our oxymetazoline nasal drops. Throat packs are used to protect the airway from the aspiration. At the end of procedure, airway should be suctioned clearly and remove any clots and debris. Coming to the retinoblastoma, these children require multiple general anesthesia sections for EUAs, and these kids used to come to us for as frequent as 4 to 8 weeks. Another important aspect I wanted to tell is intraarterial chemotherapy. This intraarterial chemotherapy is known to produce hypokinesis of heart, something known as myocardial stunning, that can occur up to 40% of kids. And atypical bronchospasm can also occur, and review of the previous anesthetic records are mandatory because these kids might have gone to higher centers for the intraarterial chemotherapy and they might have recorded a myocardial stunning. So if it is prudent, we can wait up to 4 weeks for the myocardium to recover before accepting for general anesthesia for a second sitting. Also, the retinopathy of prematurity, the cryotherapy, laser photocoagulation, anti-VEGF monoclonal antibodies, all these treatment we may require general anesthesia. So most of the cases are done under mild sedation or topical agents. Many cases may need a postoperative support in the NICU if we are giving general anesthesia. And retinopathy of prematurity, again, the ROP kids come for when the general anesthesia or sedation is necessary. Our concerns include the respiratory and cardiovascular prematurity, hypothermia, and hypoglycemia. So we accept these kids with a consent to shift to NICU in the postoperative period. And we keep the operation theater temperature to 25 degrees Celsius and active warming, including the warm beds and warm blankets and hot air fans, etc. are used. Many of these infants will require postoperative ventilator support in NICU. Thank you very much for.
Thank you, Dr. DWIDEEP Chandra, for that exhaustive coverage of all the conditions which need anesthesia. Thank you. So actually we have a PowerPoint sent by Dr. Sumita Agarkar, who was supposed to be here with us, and her flight has been preponed a bit, so they are going together. So she has sent, if anyone would like to see the, she is supposed to talk on IOL power calculation in children, which again is a debate topic where undercorrection, which type of undercorrection has to be done, or which IOL formula to use. So if anybody is interested, I can put the, would like to see. So can you please?
Ma'am, can I ask a question
Yeah.
to the
Dr. Sumita
who
Agarkar.
presented earlier?
Dr. DWIDEEP.
He's an anesthesiologist. Yeah. So actually, I have a child who's come for squint surgery, and with a sudden onset of squint. So when we evaluated him, everything was normal except he had a positive anti-acetylcholine receptor antibody. So that came out as positive, but his myasthenia workup was negative otherwise. No ocular or evidence of ocular or systemic myasthenia, no ocular motility limitation. So we repeated it again. Again it came out as positive. So now they have done all therapies and now they want us to do surgical correction. So what would be your take on this?
Basically, it's a very tricky situation because these kids can go for postoperative ventilation. So what we do is, these kind of kids, we avoid giving paralytic agents. What we do is, we will keep the baby under anesthesia, that means GA, with a spontaneous respiration, or with a little bit of support from the ventilator. So in the advanced ventilators, we have modes like SAMV, that means synchronized intermittent mandatory ventilation, or CPAP also we can give. And in the most advanced system, what we are using in Contrast Eye Hospital, we have something called as PSV Pro. That means the patient's on ventilation, but the ventilator is giving some pressure support to the baby so that the tidal volume is maintained. So the respiratory effort arises from the baby itself. I wanted to make it as simple as possible so that ophthalmologists understand this. So basically, the baby is spontaneously breathing, but the ventilator is giving some pressure to the baby so that the tidal volume, the ETCO2, everything is maintained normally.
So
basically we avoid all the paralytic agent we are avoiding. But still, like in case of something goes wrong, we may have to have a backup plan. So we need to counsel the patient party for the postoperative ventilation, because in case something goes wrong, you are unable to intubate with the spontaneously breathing baby, we may have to paralyze the baby. We may use a short-acting agent, but still the baby can go ahead, go for a complete paralysis. In case this, I had an experience with one of the babies who was not detected these anomalies pre-operatively. So we have given paralytic agent, and this baby had to be ventilated for next 24 hours. So usually, even if with all these problems, the babies come out of ventilator in next 24 hours. So we can take up the case, but with a lot of counseling and a lot of cost counseling and explaining all this possibility to the patient party.
Just one point I wanted to add, thank you for that comment, that yes, anesthetic agents can also produce sometimes problems in the surgery, like fentanyl. And fentanyl can produce pupillary constriction, but then it goes away with intracameral adrenaline. Another thing is when you have a high ETCO2, it can produce a high positive pressure. So,
exactly.
So that is another thing. If you're having a lot of positive pressure, I first look at the ETCO2 and I request my anesthetist if they can reduce the ETCO2 a bit.
Yeah, exactly.
Especially towards the end of the surgery, this happens when you're
and also it increases the bleeding and your intraocular pressure, everything. So ETCO2 is a major culprit, like high ETCO2 is a major culprit in increasing IOP, increasing bleeding, and problems in the postoperative period. So I always put these babies into the ventilator whenever possible, because I don't want to do a back ventilation, so that one of the problem with the back ventilation is that the ETCO2 sampling won't be adequate. So most of the time what happens with the hand ventilation is that you will be inadequately ventilating the baby. But with an inadequate sampling of ETCO2, the ETCO2 may be shown as normal, but the actual ETCO2 will be higher. So I always put them on, our ventilator have all the facilities like supporting the spontaneous ventilation, paralyze the baby, everything we can do. So I put...
Which is your machine?
that is just a GE NXT, that is just for your information, it costs just 8 lakh rupees, 8 to 10 lakh rupees.
Very small babies will still hand ventilate, that's why I'm asking.
Small babies to the what weight?
It's probably less than 10 kgs or...
No need. You can always ventilate the baby. In our setting,
I think we are operating even babies up to 1.5
kg, like that.
kg.
We are also operating, but my anesthesiologist prefer to
because
hand ventilate when the baby's weight is less.
Because they feel more confident that this. But for your information, a couple of weeks ago we have ventilated 2.4 kg baby for a long retina surgery that lasted for more than 2 hours. So that is more beneficial to the baby, beneficial to the surgeon, beneficial to the anesthesiologist as well, because you are controlling everything and you have the adequate values shown in the monitor. When you are hand ventilating, all the things are a guesswork. The pressure you are giving, the sampling rate, the temperature, everything is a guesswork. But oxygen level, everything is a guesswork. But when you are connecting that to a ventilator, all these are correctly monitored.
Thank you, Dr. DWIDEEP. That was very